So this is like a blast crisis-like situation. So depending on the patient's condition, we would do imaging and all, because a lot of extramedullary disease is also common in all of these diseases. So whether there is any chloroma or any other, sometimes even lymphoma, leukemia can concurrently be there, lymphoblastic lymphoma and all. Then after that, I'll start treatment depending on this condition. There is not much data on how to treat such AML, transformations, because it is uncommon to have transformation to acute myeloid leukemia, this disease. Unlike others which have FGFR and other translocations, PDGFR alpha translocations hardly transform. So if the patient is fit, I would prefer to give an 3+7 based injection, followed by consolidation with HIDAC, or there is no data for venetoclax and azacitidine, but if he is unfit with all the cardiac conditions, by now we don't know how his condition is, I would maybe consider aza plus venetoclax, followed by of course, since it's an MP and blast crisis, we have to go for transplant irrespective of MRD or whatever status. So depending on his and along with that, since on imatinib he developed this disease, and since he has a mutation, we would add some other agent. There is, for resistance, there is not much data again, but in GIST and all, in resistant patients, people have tried various things like avapritinib and even ponatinib also. Since ponatinib is available, I would give ponatinib, maybe 45 mg at that dose. And after I give that, suppose he goes into remission and I consolidate him, I would take him up for transplant if he has a match. If he has a match, I won't wait for consolidation. So if suppose we get a match sibling donor, after he's attained remission, I would take him up for transplant, maybe with a flu-vu 3 if he's fit, or a FTT flu tryout thiotepa if he's fit. Otherwise, I would give with, that is my